Hi everyone, Dr. Manjula here. Today we are going to discuss some of the previous year questions from AIMS NORCET examination. Let's start. So let's see the first question. A normal adult compression to ventilation ratio with two rescuers is 30:2, 15:2, 2:30, 15:3. So the answer is, please read the question carefully. This is an adult ventilation compression ratio and there are two rescuers. So what is the answer? The answer is 30:2. Okay. So the 15:2 ratio is used only in infants and children when two rescuers are present. So in adults, whether it is one rescuer or two rescuer, the ratio is 30:2. And the sequence is CAB, that is compression, followed by airway and breathing. So just a quick recap of our basic life support. First is to check the response, that is you tap and shout and ask, are you okay? Now, if there is no response, then you call for help, like, calling the 108 or get a, and also get a AED. Then check the breathing and pulse, maximum for 10 seconds, okay, 5 to 10 seconds. And if there is no breathing, no pulse, then you have to start CPR. So that is very, very important point, when to start the CPR. Then when you're giving the chest compressions, there are certain aspects to remember. You could have questions from any one of this. So the depth should be at least 2 inches, that is 5 centimeter, and the rate should be between 100 to 120 per minute. And how do you position the hand? At the center of the chest and allow for full recoil. After a deep compression, then you allow the chest to recoil completely and give 2 rescue breaths. So 30 compressions, 2 breaths. Then lift, the head has to be tilted and the chin lifted to allow for the air to enter, and observe for the chest rise. Okay, so keep continuing the CPR, that is the 32:2 cycles, until the help arrives or AED arrives, or till the victim responds. So it is always recommended to use AED as early as possible. There are voice prompts in the AED. Follow those prompts and resume CPR after the shock again. Next question. While using a cardiotocogram, the fetal heart rate to uterine contraction relation shows that the fetal heart rate gradually decreases and returns to baseline, but the nadir of the deceleration occurs after the peak of each uterine contraction. What does this indicate? Early deceleration, late deceleration, variable deceleration, acceleration. So now here we are talking about the recording of the cardiotocogram, where you record the fetal heart rate in relation to the uterine contraction. So in this question, what does it say? It says that the fetal heart rate gradually decreases and returns to baseline. So it is touching the baseline, but the nadir of the deceleration occurs after the peak of each uterine contraction. So the answer is late deceleration. So here in this question, what does it say? The FHR gradually decreases and returns to baseline, but the nadir means the lowest point of deceleration comes after the peak of contraction. So this pattern is very typical of late deceleration. And why late deceleration is very, very important or very dangerous? Because it indicates fetal hypoxia due to reduced oxygen during contractions. So it always requires close monitoring, because we may have to intervene immediately or may terminate the delivery, or whatever it is. So this late deceleration is very dangerous. Okay. What are the other types of decelerations in the tocogram? It is early deceleration, which starts and ends with the uterine contraction, and the cause is head compression. Then late deceleration, which we already discussed, it begins after contraction peak, and the cause is uteroplacental insufficiency, which is dangerous. Then variable deceleration means there is an abrupt drop and there is no fixed pattern to it. So that indicates the cause is cord compression. Then acceleration. Acceleration means fetal heart rate increases above the baseline, which is normal, and it is a sign of healthy fetus. Coming to the next question, the contraindications of nasopharyngeal airway is basal skull fracture, sedated patient, unconscious patient, and during dental procedures. So, contraindication for nasopharyngeal airway. The answer is basal skull fracture, skull base fracture. Now, a nasopharyngeal airway is actually a very soft and flexible tube that we insert through the nose into the nasopharynx. And what is the purpose? To maintain a patent airway. Okay, now this is contraindicate. When you should not do this is when there is a skull fracture, especially cribriform plate fracture. To be very specific, cribriform plate fracture you shouldn't use. Why? Because this can go into the cranial vault and it can cause infection or brain injury. So through that fracture, through this area, it can get into the cranium and it can even cause cranial injury, brain injury, and also infection. That is why it is contraindicated in basal skull fracture. So you should never use in this nasopharyngeal airway if there is facial trauma, if there is a CSF rhinorrhea. So when there is a CSF rhinorrhea, we suspect that there is a basal skull fracture. So never do this when there is a CSF rhinorrhea, as well as raccoon eyes or periorbital ecchymosis. Raccoon is an animal, and raccoon eye looks like a complete ecchymotic lesion around the orbit or around the eyes. So that also is an indication of basal skull fracture. So in such cases, do not use nasopharyngeal airway. This is a very important question. What are the other options which were given? See, sedated patient, unconscious during dental procedures. Let us check the other options as well. So sedated patient, it is safe to use. It can be used if the airway tone is low. In unconscious patient also it is safe to use. It is anytime preferred over oropharyngeal airway if gag reflex is intact. Then during dental procedures, yes, fine. It's not typically contraindicated unless the nasal root is obstructed. So NPA goes through the nose, but never if the skull is cracked. Just remember that. Next question, complication of high flow ventilation. Aspiration, pneumothorax, diaphragmatic hernia, COPD. So the answer is pneumothorax. Now, high flow ventilation, such as in mechanical ventilation or bag and mask ventilation, it can really cause pneumothorax. Pneumothorax means what? There is air in the thoracic cavity. Okay, air leaks into the pleural space. That is called as pneumothorax. So the problem with pneumothorax is that air will push the lung to one side, creating the collapse of the lung. Now, when you are using mechanical ventilation or even bag and mask ventilation, if you give excess pressure or excess volume, it can lead to barotrauma or volutrauma because of the high flow pressure ventilation, and that can cause rupture of the alveoli. So I think you got the point. See, in mechanical ventilator, if you're using so much of pressure or too much of volume, it can cause barotrauma or volutrauma. If there is too much of pressure, it causes barotrauma. If too much of volume, it causes volutrauma. And this high pressure ventilation will result in rupture of alveoli. Even if you are using the bag and mask ventilation, there is so much of pressure you are delivering to the lung, then it will cause rupture of the alveoli. This is especially very risky in neonates and people with lung diseases, and also if you are resuscitating with improper ventilator settings. Now, the other options were aspiration. Aspiration is because why it happens is if you have improper airway protection, then aspiration can occur, but not because of the high flow. Diaphragmatic hernia has no association with the ventilation. It is trauma related or congenital. COPD is a chronic disease. It has nothing to do with high flow ventilation. Next question, identify the FiO2 rate in the given Venturi mask. So in this picture, now in NORCET questions, you can expect image based questions. Okay, they'll give you pictures of some instruments, some equipments, some catheters or some things like that, and will ask you questions based on that, either to identify the image or associated questions. Now this is such an example. Here they have given a Venturi mask and they are asking for the FiO2 that is delivered by this device. Now you can see that the color is red, correct? So when you see the image, your attention should go to that color red. Now let us see the choices: 40%, 31%, 60%, 28%. So the correct answer is A, that is red. Okay, red is 40%. So this is very important area that you should by heart. If the color of the Venturi mask is blue, it delivers FiO2 24% and oxygen of 2 to 4 liters per minute. So this is usually used in COPD patients who require low oxygen. Then white gives is 28%, 4 to 6 liters per minute, used in COPD patients with mild hypoxia. Yellow is used, yellow is delivers FiO2 of 35% and oxygen of 6 to 10 liters per minute, used in moderate hypoxia. Red 40%, 8 to 10 liters per minute, moderate to severe hypoxia. Green is 60%, 10 to 15 liters per minute with for high oxygen needs. All right. Now next question, a patient is having a calcium level of 7 milligram per deciliter. Identify the ECG changes. So when you get a question like this, so you should know what 7 liters means. 7 milligrams per deciliter means. Is it hypocalcemia or hypercalcemia? Then look at the options. T wave inversion, prolonged QT interval, prominent T wave, peak Q wave. So the answer here is hypocalcemia. The option 2, hypocalcemia. Now serum level of 7 says that it is hypocalcemia because the normal levels are usually 8.5 to 10.5 milligram per deciliter. This value also is important. Milligram per deciliter. Now what is the ECG change in hypocalcemia? You can see that the QT interval is prolonged because there is a delay in the ventricular repolarization. So this also increases the risk of torsades de pontis, which is a dangerous arrhythmia. Now to remember this quickly, I can give you a mnemonic. Low calcium means long QT, okay, which means prolonged QT. And high calcium, short QT. So you can remember it like that. So what are the other options given? T-wave inversion, it is seen in ischemia and not in calcium changes. Prominent T-wave is seen in hyperkalemia, not in hypocalcemia. PQ wave, where is it seen? It is seen in hypocalcemia. Okay. So the electrolyte imbalances and the ECG changes associated with it is very, very important area for you to keep in mind. Next question. Identify the abnormalities seen in this patient. So the pH is 7.25, PCO2 is 40, bicarbonate is 22, and sodium 150, chloride is 100. So what abnormality is seen here? Metabolic acidosis, respiratory acidosis, metabolic alkalosis, respiratory alkalosis. So the answer is metabolic acidosis. Now, how do you interpret ABG? That also is a very important area for you to know. So in this question, the pH is given as 7.25 and you know that the normal range is 7.35 to 7.45. So what does this mean? The pH value is less. That means there is acidosis running here. The next value that you have to look at is PCO2. So we see that in this question, the PCO2 is 40 millimeters of mercury. Okay, 40 millimeters. Then what is the normal range? 35 to 45 millimeters of mercury. So you know that this is normal. So there is no respiratory problem involved here. So it has got nothing to, this acid imbalance has got nothing to do with respiratory aspect. So it is normal. Now you look at the bicarbonate. Bicarbonate shows 22 milliequivalents per liter, and the normal bicarbonate level is 22 to 26 milliequivalents per liter. So this shows that it is towards the lower border, or rather normal, towards lower or normal. Okay, so the reason here is that it is not respiratory, but it is metabolic. Okay, so metabolic cause is responsible for the acidosis here, and that is how you get the answer as metabolic acidosis. So what is metabolic acidosis? We have already discussed that there is a pH is low, so it is acidosis. PCO2 is normal, so it's not a respiratory problem. Bicarbonate is on the lower end. It suggests loss of base or acid gain. So that's why it is metabolic acidosis. Why other options are incorrect? The other options were respiratory acidosis. Now, if it would have been respiratory acidosis, the PCO2 value would have increased. It would have gone above 45 millimeters of mercury. Okay, I hope you understand this. You know that it is, the abnormality is acidosis because the pH is low, right? The 7.25 was the pH in the question. Okay, so here 7.25, yeah, right. So if it would have been a respiratory problem, then when you look at the PCO2, it should have increased. But in this question, it is not. It is normal, right? Now, metabolic, what were the other option? Metabolic alkalosis. If it is an alkalosis, then definitely pH will be more than 7.45. Okay, but that's not right here in this question. And similarly, if it is a metabolic alkalosis, the bicarbonates also will be elevated more than 25, 26 milliequivalents. It would have gone above. So that also is not right. Then comes respiratory alkalosis. Again, if it is an alkalosis, the pH would have gone high, more than 7.45, but that is not the case in this question. And also, in a respiratory alkalosis, the carbon dioxide would have gone down, less than 35. So that also is not correct in this particular question. Okay, so these are all the wrong options. Next question, during suctioning, the patient complains of respiratory distress. What should be the nurse's action, first action? Okay, so that is also important. When you read the question, keep marking the important key words. So the first nursing action should be immediately remove the suction catheter, suction rapidly in 5 seconds and remove the catheter, call senior nurse, call the doctor immediately. So the patient, while suctioning, the patient is undergoing respiratory distress. What should be done first? Immediately remove the suction catheter is the answer, because anytime if there is a respiratory distress, whatever you are doing, you have to stop the cause, right? So remove the suction catheter immediately, because suctioning can cause hypoxia, it can cause vagal stimulation and lead to bradycardia, it can cause mucosal trauma and airway obstruction if prolonged. So just because I am talking about suctioning, I have also given here what all problems suctioning can cause in the patient. So it can lead to hypoxia, vagal stimulation, which can induce bradycardia, mucosal trauma, because the mucosa can get entrapped in the suction catheter, and also airway obstruction if you are prolonging it. So when you remove the catheter, it restores the airway and stops the any further distress. So the answer is immediately remove the suction catheter. So what were the other options? Suction rapidly and remove. So never do that, because it will only worsen the hypoxia. Call the senior nurse. Definitely you can do that, but first in the question they have asked first, correct? So first is to act immediately and give the patient relief. Then you can inform the senior nurse. Calling the doctor also is not the first step. First step is always immediate intervention. So these are some of the points that general tricks to solve questions like this. Okay, anything that is has to be done immediately, you have to do it, and then only calling, informing, all that happens. Otherwise, by the time you are informing, the patient will be dead. Okay. The next question, the earliest symptom of hyponatremia is fatigue, ataxia, thirst, weakness. Earliest symptom. Okay. So here these two are the words. Earliest symptom of hyponatremia. What is it? It is fatigue. Hyponatremia means decreased sodium levels less than 135 milliequivalents per liter, and the earliest sign is fatigue. Now, sodium actually affects your nerve and muscle function. So that's the reason why the earliest symptom, or the first and the noticeable symptom will be fatigue, which will later on progress to headache, confusion, muscle cramps, and seizures if you are not correcting the hyponatremia. So low sodium slows down the cells. So it starts with fatigue and ends in confusion. So you can remember this very easily. And why the other options are not right? Ataxia appears in moderate to severe hyponatremia. Okay, so it is not earliest symptom of hyponatremia. Later on it develops. Thirst is more typical in hypernatremia, not in hyponatremia. Weakness is common, but first what appears is fatigue. Okay. Next question, the earliest sign of hypocalcemia. The earliest sign of hypocalcemia is twitching, negative Chostek sign, weakness, exaggerated deep tendon reflex. So here also the earliest sign of hypocalcemia has been asked. So the answer is exaggerated deep tendon reflex. Now what is hypocalcemia? When the calcium level goes below 8.5 milligram per deciliter. It is called hypocalcemia. Now you know that calcium plays a very vital role in neuromuscular excitability. So when the calcium level goes down, this muscles become, or it increases the excitability, leading to hyperreflexia. Hyperreflexia means what? The reflexes are increased or exaggerated reflexes. That is the early sign of hypocalcemia. Okay, so low calcium will cause excitability. Okay, that is the key thing that you should understand. So hyperreflexia, that's why hyperreflexia is the early sign. So muscles and nerves become more irritable. So you get it as exaggerated deep tendon reflex, and it is seen before visible twitching or tetany. Okay. So you know that hypocalcemia causes tetany. Everybody is aware of that. But even before the signs, any visible signs of tetany comes, what you can earliest detect is exaggerated deep tendon reflex or increased deep tendon reflex. Okay, why that occurs is because calcium, the low calcium increases excitability of the muscles. So that is why deep tendon reflex are the early indicator, which is very sensitive early indicator. I hope that is clear. Okay, later only you will find tetany and signs of tetany like Chostek's and Trocheau's sign and all of that. So what were the other options? Twitching. Twitching occurs later, and it is with severe hypocalcemia. So as the calcium level drops further, then you get twitching. Before that, you get increased deep tendon reflex. Then what is the next choice? It was negative Chostek sign. No, negative Chostek sign. No, it is not in hypocalcemia. In hypocalcemia, it is positive Chostek sign. Then weakness, again, it's more associated with hypercalcemia and not hypocalcemia. Okay, so to quickly remember, low calcium means high reflex, and first is DTR or deep tendon reflex, then twitches and tetany. Okay, this is the order how it appears, right? Next question is, patient's vitals show that BP is 120 by 66, pulse is 88, SpO2 is 99, and respiratory rate is 23. So this patient should be classified in which triage? Red, yellow, green, black. So here the question is about triage. Triaging is also another important topic which you should remember. So all the vitals are given and they are asking under which triage or which color code you will designate the patient. It is green. Now you see the BP of this patient is 120 by 66, which is rather normal, and the pulse is 88, which is also normal, and the SpO2 is 699, which is again normal oxygenation. Respiratory rate is 22 per minute, mildly elevated, but you can consider it as a normal, and means it is still acceptable. There are no signs of distress. So this patient is rather stable, right? There is no breathing compromise, there is no circulation compromise. So this person can wait. He can walk, he can wait. So that's why we have put him under green triaging. How about the other? Okay, this is important. This is a basic triaging color coding. So when a red color is given, that means he requires immediate attention. He has some life-threatening problems and urgent attention has to be given. If it is yellow, that means it can a delayed category. They are serious, but they still can wait. Green means they have, there are some minor injuries where they can walk, they are stable, and they don't require any urgent intervention. And black means they are dead already, deceased or injuries incompatible with life. All right. Next question. A patient is having a temperature of 104 degree Fahrenheit, BP 140 by 90, respiratory rate 28 per minute, and the pain scale score is 5. Which factor you will primarily manage in this patient? Now, a lot of values has been given here. So, what will be the first thing that you are going to manage here? Temperature 104 degree Fahrenheit, BP 140 by 90, respiratory rate 30, or pain scale score of 5. Which is your priority to manage? So the answer is 1, temperature 104. Why? Because it is a high grade fever, right? So it can be dangerous and life threatening if you don't intervene properly. So why is it so we have to immediately intervene? This is because if the temperature keeps continuing like this or maintains like this, high temperature is there, it can lead to febrile seizures, right? Then second thing is it can lead to delirium or altered mental status. Again, when the body temperature is high because of the high fever, then the patient can go into dehydration because of the sweating and the profuse sweating that happens. They can go into dehydration, and tissue damage or organ stress can also happen. That's why it is very important to bring down the temperature first. So if the temperature is 104 degree, it also indicates that there is some serious infection happening in the body or some inflammatory responses going on which needs immediate attention, right? All right. So these are all not of concern or not at all life-threatening, the other options. So a rule of the thumb is that always treat the most urgent and potentially life-threatening issue first. Now, in this case, in our choices, it is a fever. So that has to be attended first. Next question. Patient has temperature 103 degree Fahrenheit, heart rate 110, respiratory rate 23, BP 132 bar 66. Which factor would you primarily manage in this patient? So a similar question. So first what you have to manage? Temperature 103, heart rate 110, respiratory rate 23, or BP 132 by 66. Can you guess the answer? So here also temperature has to be managed because we have high grade fever and that should be of concern, especially if it is causing compensatory changes in other vital signs like heart rate if it increases or respiratory rate. Now the temperature is 103, which is high grade fever. It needs to be controlled. 110 heart rate, it is likely to be elevated because of the fever. Respiratory rate is slightly elevated again due to the fever. BP is normal. So whatever changes that you see in the vital signs is also because of the increase in the temperature. So in that way we have to think. Okay, so here fever is the priority because it is causing tachycardia, which can increase the oxygen demand, dehydration, and can often lead to febrile seizures. So managing the fever will stabilize the other changes in the vital signs, right? So here treating the underlying cause, which is fever, is rather than just the symptoms, is important here. Next question, according to ABC, which of the following describes improper cardiac circulation? Hypotension, diminished pulse, tachypnea, capillary refill time less than 3 seconds. So you know what is ABC, right? Airway, breathing, circulation. So accordingly, the answer is 1, or hypotension. Now, A, B, C. Here we are talking about circulation, or C, which refers to the blood flow to the organs. Now, the answer is hypotension. Why? Because hypotension will lead to improper circulation. So, hypotension means the BP is low. Because of the low BP, the circulation to vital organs also is reduced. And this is one of the most direct sign of compromised cardiac output or vascular failure. Now, when your heart is not able to pump effectively, or when the cardiac output is compromised, then you get low blood pressure, or you see that there is hypotension, and that will reduce the circulation to the vital organs. So the answer is hypotension. Why other options are not correct? Diminished pulse means it suggests poor perfusion, not as definitive as a low BP. So you might be getting confused with these two options, right? What is it? Yeah. So you might, these things I'm sure you will not, but these two you may get confused, hypotension or diminished pulse. Now, diminished pulse can occur in decreased circulation, as well as if there is in decreased cardiac circulation, as well as if there is a decreased peripheral circulation. Okay. Now, it is not, that's why it is not very definitive of a decreased cardiac circulation or decreased BP. It's not as definitive as a low BP. So low BP is the definitive. Definitive means paka sign. It is not pulse, diminished pulse. Tachypnea is related to breathing and nothing to do with circulation. Then capillary refill time less than 3 seconds means it shows adequate perfusion. If it is more than 3 seconds, then it is inadequate peripheral circulation or perfusion happening to the periphery. So this is okay, shows normal or adequate perfusion. So always in circulation problems, look for low BP as the sign of poor cardiac output. It's not pulse, it is first is BP. Then only BP is definitive, then only comes the pulse. Next is, during IV administration, which of the following drug causes extravasation and damage to the site? Extravasation and damage. Diazepam, epinephrine, phenytoin, ranitidine. So the answer is phenytoin. Phenytoin is because it is highly alkaline. Okay, its pH is more than, its pH is approximately 12. So it's a highly alkaline solution, and it will cause irritation to the tissues. That's how it leads to severe, if it extravasates, if it comes out of the blood vessel into the tissue, there is severe tissue necrosis and will lead to something known as purple glove syndrome. Purple glove syndrome means there is pain, swelling, discoloration, and possible gangrene. And it will also lead to vascular damage. So you must be very, very careful when you are administering phenytoin because it can lead to purple glove syndrome. So give it slowly through a large bore vein with a filter. That is the best way to administer phenytoin. Very slow IV using through a large bore or a bigger vein and also with a filter. So this is how you can just remember. Phenytoin will cause purple glove syndrome and painful, which can lead to painful extravasation. Then diazepam, the other choices are diazepam, which is an irritant, but it is less severe than phenytoin. Epinephrine, it can cause vasoconstriction, but it doesn't cause necrosis when extravasated. Ranitidine is not a, it is generally safe for IV. It is not a vesicant, or it is not a drug that causes damage to the tissues. Okay, so in this question, if phenytoin would not have been there and instead maybe some other drug, maybe paracetamol or something would have been there, this would have been your answer, diazepam, because it is also an irritant, but it is not as dangerous as our phenytoin. Okay, so that's all about today's question answer discussion. I hope you liked it. If so, please do like, share and subscribe. Thank you so much.